Welcome to the Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm your host, Dr. Andrew Wilner. Today, I have the pleasure of speaking with Dr. Joe Sherman. Dr. Sherman is a pediatrician and physician coach. He also has years of experience doing medical missions, which is our topic for today. But before we get started, I'd like to thank our sponsor, locumstory.com. If you're considering locum tenens, either full time or on the side, you probably have a question or two, or 20. Fortunately, locumstory.com has the answers you need. It's packed with unbiased information and advice from physicians like you. Locumstory.com has nothing to sell, it's simply a resource for information. You'll find super handy tools that let you see locums trends for your specialty, compare different locums agencies, and there's even a quiz to help you decide if locums is right for you. Locumstory.com is the perfect place to start if you want to learn more about locums. And now, Dr. Joe Sherman, welcome to the program.
Thanks so much for having me. I appreciate it, Andy.
Joe, so I know you're a pediatrician and I know you're pretty active coaching.
Hmm.
But when I was looking at your bio, and we talked earlier, you've done a lot of medical mission work. And that piqued my interest because about 11 years ago, it's kind of a long story, but I ran into a guy from the Philippines, and that evolved into annual trips for me. And I became the medical director of Lingkod Timog, which is a nonprofit medical mission group. And I would say that it really opened my world. And I want to hear, but those were only 1 or 2 weeks a year. But I know you've spent literally years doing medical missions. So first, tell us about a little bit about your medical training and background, and how that segged into "Bye, honey, I'll be back in 3 years," or something to that effect.
Well, first of all, most of the long-term trips were not bye, honey. It's let's go, honey. And
Oh, great.
usually, and usually it was my wife who was saying that to me, let's go, honey. We're going on another trip. So that was a major part of the long-term story. But I have to say, in the beginning, I went to medical school as well as residency in Richmond, Virginia, at Medical College of Virginia, Virginia Commonwealth University. And I'm originally from Washington, D.C., so that was just right down the road. And when I was in residency, this was in it was med school and residency all in the 80s. The idea of leaving the hospital during residency and doing anything outside of even the building was kind of unheard of. And for me, I had one elective. It was called an away elective my senior year of residency in pediatrics, where most people kind of went to a place where they like wanted to practice or somewhere else where they knew somebody. For me, I had friends who were volunteers overseas. And one friend was in Belize as a volunteer. And she convinced me that I should take the month and work in a clinic on the border of Belize and Guatemala for a month. So I didn't know anything about it. I had never been out of the country. Our family we didn't have a whole lot of money. We didn't travel much. So it was my first trip out of the country. I flew down, like left the hospital, flew down to Belize and got into this pickup truck, was driven across the country. It's a small country, went from Belize City to the border of Guatemala to this tiny little town of indigenous people who lived in that area, and met a host family who showed me into this little apartment. And there I was for a month. I was the only pediatrician at the time, I was told, in the country of Belize, because it's a tiny country and it wasn't much. And I was a senior resident. But I have to tell you, that experience of being on my own and being able to create myself in any way I wanted in a brand new culture and interact with the community on the street, on the road, the dirt road, as well as in the clinic, as well as, playing basketball with them and everything together in a different language, a different culture. It just made me come alive. And I just felt tremendous satisfaction, tremendous fulfillment. And what a switch from the wards of residency. So that was my first experience overseas.
Sounds like you fell in love.
I did. I really did. And, the strange thing was, I was there for 1 week and I started to feel a little sick and I started to feel itchy on my skin. And I looked down and there were a couple of bumps. And I thought, oh my God, I must have smallpox. And I, I remember I went to the nurse who ran the clinic and I said, do I have smallpox? Because I didn't know anything about smallpox at the time. I thought it had been eliminated. And she said, no, you have chicken pox. I went, oh my God, I had never had chicken pox.
Very
I
appropriate for a
knew,
pediatrician. There you go.
well, I was still in residency and I had gotten there were a couple of exposures I had where they isolated me until I was able to go back. But I had contracted it in the US. I broke out 2 weeks later in Belize. So one of the weeks I was in misery with chicken pox, secondary infection. And so I called my chief resident and I said, I missed out on a week of my month. Can I extend it? Can you find coverage? Because I really want to be there for the whole experience. And we worked it out. So it was great.
Let me just put in kind of like a little sidebar, is that you had, because I consider this podcast a little bit of a public service information source, that you had chickenpox in Belize. I had chickenpox in Fall River, Massachusetts, but my son will not get chickenpox because there is now a vaccine for chickenpox. So you just told us that you were so sick you could not work for a week. You had secondary infection, and all of that does not have to happen to this current young generation because we have a vaccine. So, take that for what it's worth. But I just wanted to take advantage of your misadventure there. Okay, pick up the story. You had chickenpox. You stayed an extra week.
Yeah.
Went back to was it Virginia? Yeah.
Yes, exactly. Richmond, Virginia.
Graduated,
Mm-hmm.
top of your class.
Somewhere up there, I guess. It would
I
always
think
say, what do they
so.
say? P equals MD. Is that what? Yeah. So as long as you pass, you still get your MD, you're good.
And
So
then what happened?
so then I returned to Washington, D.C. to because that's what I wanted to do, return to my hometown. And I was a native Washingtonian. My parents, my grandparents, one of these kind of rare city kids that, had multi-generations there. And I I'll tell you that experience, well, I think my residency in an inner city environment on the East Coast, plus my experience overseas working in that clinic in Belize, really established a commitment inside of me to somehow serve underserved populations of kids and families. And that really, I think that jived very well with kind of my values that I was brought up in a big kind of old traditional Irish Catholic family, and baby boomer kid. So returned to DC and I started to work in private practice. I lasted 1 year. I was also volunteering in this community clinic that was attached to a shelter in the city of DC. And that's where I really came alive. I loved it there. And the reason is because we could work together with social workers, housing advocates, shelter coordinators, legal aid, everything together for families. And that's where I felt I thrived. So I ended up getting a job at DC Children's Hospital, Children's National Medical Center, as this young 29-year-old attending in the pediatric department there in the general peds division. And so I was the age of most of the residents. And during that time, I kind of wanted to continue to have this connection overseas. And so another friend who was associated had gone to Creighton University, connected me with a program called ILAC, Institute for Latin American Concerns. And Creighton University's medical school, dental school, pharmacy school, nursing school had a campus in the Dominican Republic. And every summer, they would take practicing professionals of all of those professions, combine them with trainees, and take 2 weeks, go down to the Dominican Republic, hike up into the mountains to small villages, and provide some medical care along with community health workers in the Dominican Republic on the border with Haiti. So our patients were both Haitian as well as Dominican. And that was another situation where I was living with a family in this kind of little grass hut in the middle of nowhere, but with a group of students and eager people who really wanted to learn about the culture, about what it's like to work together, how to deal with very little resources and just try to make do. These were experiences that I love to do. So I found time to do that twice over 5 years while I was there. No, yeah, twice over 5 years. So that was what continued me in international health. It was called international health at that time. I don't know, global health became the term now, but most of what I was involved in was as a volunteer. And it was either linked to a university, sometimes a faith-based organization, and sometimes a secular organization. So Dominican Republic was then my next venture overseas.
Well, it's very interesting. I think you were about 30 years or more ahead of your time. You mentioned that one of the values of working with the in that inner city clinic with the social workers is that you identified that social determinants of health is at least as important to address as having access to antibiotics when it comes to caring for children, I would say especially, but also, medical care in general. And of course, this is a big theme today, but I don't remember hearing too much about it. I think we're more or less in the same generation way back when. So kudos to you for figuring all that out and getting into the network. And I'll just comment on my own medical mission experience. The connection with the other people who volunteer. I think that's the key. Everyone's a volunteer. So they have chosen to be there. And it costs money actually to volunteer. It's the money that you're not earning that you could have been earning if you were working. And then there's usually incidental expenses. And our mission, for example, we pay our own travel and sometimes we get a hut, but otherwise it's in a hotel and it comes out of your own pocket. It's usually not a whole lot, but nobody's there for the money, I guess is the bottom line. Everybody is there because they want to do good. And somehow that is uplifting, I would
Mm-hmm.
say. It lets you focus on your job, for one thing. I remember the first mission we did, there was no paperwork. I said, well, who's tracking, what we're doing? And it was like, I had a little pocket notebook. I'd write down the patient and their diagnosis. I'm also an internist, so I was
Mm-hmm.
practicing as an internal medicine doctor most of the time. If there was a neuro case, I did that. Um, but yeah, no medical records. You're just
Mm-hmm.
helping the person in front of you, and
Yes.
it's unique, right? It's
Yeah.
not like practice anywhere else.
Yeah. Yeah, that's true. I mean, I think as I think about it, especially now with all the technology and information, and as a coach and facilitator trying to address the well-being of practicing physicians now, When you're overseas, electronic health records don't exist, or health records often don't exist, like you were saying. It's just you and the patient and the families in a culture where time slows down. And that's the other thing about it. I think it's a huge advantage for us today in our society where everything is moving so fast and information is coming at you from all different places. And the practicing physician has patient portal, emails, messages, lab reports, everything funneled into this screen in front of you. And all of a sudden, you're out in the middle of nowhere, often outside, often with other people, and you're the expert. You're often bringing great knowledge to that setting, and probably most importantly for me is that you're learning. It's a two-way street. You're learning about how to approach things differently, how to be innovative, how to include whatever are the indigenous and traditional practices of the culture, especially long term. And I would say my real overseas experience occurred after I got married, and my wife had spent a semester, a year abroad in East Africa, in Kenya. And so after we got married, we both had this itch to go overseas. So as soon as she graduated, she got her PhD in clinical psychology, and we looked to move to East Africa. And the way we had this debate, all right, Latin America or East Africa, and she kind of calls the shots. So she said, I'll tell you what, I'll make a deal. Before kids, East Africa; after kids, Latin America. And
Hmm.
I was like, okay, that sounds pretty good. So we looked and looked, and we wanted to find an opportunity for me to work for a year and not try to commit for too much longer, just a year, because we weren't sure, and somehow break even, just have our expenses paid in some way. I was fortunate enough through a connection that I had with a friend in Baltimore to connect with a clinic in Uganda, in Kampala, Uganda. And it was run by Johns Hopkins University. So now I'm connected to a university. And it was a collaboration between Makerere University, which is a university in Kampala, the medical school, and Johns Hopkins. And it was a clinical trials program for maternal child HIV transmission prevention. Now, I had held academic positions in universities, but I was a clinician, educator. I was not a researcher. So I was bringing trainees into community settings to expose them to the families and the situations of the families of their patients. But now I was joining this clinical trial that I really didn't know much about. But the director of the clinical trial, the PI, said, I don't need any more researchers or statisticians. I got all of that stuff. I need somebody to see patients. So that's what we did. I took that job and I went to Kampala, Uganda, and I was one of the clinic doctors, along with the Ugandan doctors, in seeing pregnant women and newborn babies in this clinic that was in a shed. And they were, at the time, um, uh, preventative treatment for pregnant women for HIV was just getting off the ground in the US. This was in the 90s. And so I was involved in clinics where I was treating infants, newborns of mothers with HIV. And PCR was this new test that had just been invented. And the principal investigator was big on PCR. That was him. He was a pathologist. And so we were able to test various drugs, including nevirapine. That was the major one. In giving one dose of nevirapine to women who showed up in the clinic pregnant at the time of delivery, and one dose to the baby after delivery, and reduced the rate of transmission by 50%. And this was hugely controversial because there were no antiretrovirals available anywhere in Africa at the time. And so the idea of not having antiretrovirals to treat people and only having this drug available for the clinical trial, it was very challenging. So that was kind of aside. And at the time, I was just doing the clinical work. I wasn't aware of a lot of the research implications. However, my wife and I lived there in Uganda, and we made great friends with all of our neighbors. We lived in a house, and we stayed on for 2 years, and until we she got pregnant, and then we returned back to the U.S.
Wow. So Uganda, that's even more off the beaten path, I would say, than Belize, right?
Oh yeah.
Africa. I haven't done any mission work in Africa, but from what I've read and seen, that's really a different level of lack of supplies and lack of sophistication, also lack of education in the population. Was there any antipathy? You know, where I've gone, usually well received, and that's part of the pleasure of being sort of medical mission doc. Is like, oh, the doctors are here. This is great. But I know there's some there were some conspiracy theories about HIV and doctors and vaccination, you know, and all that stuff. Did you run into any of that, or were the people just happy that you were there?
Well, it was Uganda was unique as a country in Africa, in East Africa and Southern Africa, in that the president of Uganda was the only leader in that area who admitted that HIV was a public health problem, and the only country at the time that was really doing seroprevalence testing. And and the seroprevalence at the time that we went and were living there was somewhere around 18% of the population. And this was at a time where were no medications available.
Right.
Later, when other countries started to do this testing, it was closer to 25, 30% of the population, some of the countries in Southern Africa. But in Kampala, East Africa has the tradition and the remnants of being a British colony or protectorate. Sorry, I don't know. I think it's protectorate. And so the influence of this formal British medical system and system of education was present there. And what was also present was that if you showed up with a white face and a white coat, you were automatically assumed to have all the knowledge in the world. So I was, besides being in the clinic, I was on the wards in these kind of tropical wards that were one story spread out over, the whole field, countryside. And it's the first time that I had ever worn a necktie in my pediatric practice, but that was the tradition: white coat, necktie. And these residents, who were far better educated than I was in tropical diseases, looked to me for answers for cerebral malaria and talk about
Mm.
vaccinations and diseases. I had a whole ward of measles. I saw TB. I saw tetanus. I saw diphtheria. I saw mumps, measles, just everything, every vaccinated disease I saw. And they would ask me about these things like cerebral malaria and Chaga, not Chagas, that's Bolivia, that's later. But all of these diseases, I was like, I don't know any of this stuff. You have to teach me. I'm just starting from scratch. So there was this kind of, for the people of Uganda, very humble people, very sweet, kind, welcoming people. And yet, what the Ugandans and my Ugandan medical colleagues called colonialization of the mind was very much present there. So this kind of dependency was present. And I had to work with that because I did not have the knowledge. I had to learn from the residents and the trainees about how to treat these diseases. And so we traded. I said, I know about things like child development, autism, ADHD, things that you don't treat here, but you still see. And you know all about tropical diseases. Let's exchange our knowledge. And that's really how I function there in that environment.
All right, that's great. I can see that you and I need to sit down like with your favorite beverage for a few hours, and we have a lot of stories. I want to seg a little bit back to our audience. Now, suppose a physician or a nurse or physician assistant is watching the program and they say, I'd like to do well, maybe I'd like to do. I don't know if I'd like to do a medical mission or not, but I think I want to learn more about it. Something I'm thinking about doing. Maybe it's a good burnout antidote. Maybe it's just something I ought to do. And you mentioned kids. Kids can certainly complicate it, but they can be worked into the program. So anyway, somebody says to you, "Hey, you've done all these medical missions. I think I want to do that." What do you tell them?
Do it. I guess
Okay,
that's the simple answer.
all right.
Um, you know, later on, and we haven't gotten to this, but later on, we had two kids and we left and we went to Bolivia and we lived there for 4 years with two little kids. And that was, I would say, by far the best decision we've ever made as a family. I would say that the discernment and the calculations and the angst that goes into trying to decide whether or not to do something long term, short term, everything. Once you make the commitment, once you make the decision, we're going to do it. It's like everything just kind of settles down, things fall into place. And I can tell you that it will impact you and it will impact the way that you look at your practice, your life, and the way that you look at the world much differently. It's going to have a tremendous impact. And I would say short term, meaning anything from a week to a month, or long term, meaning, you know, I would say 6 months to several years. I would say that those are two different types of decisions. But I would say nowadays with, I would say, young trainees and people who are in residency, medical school, it's rare to see anybody who hasn't already done some type of overseas volunteer experience, especially in medical school and residency. It's a whole different generation now. So
Right.
it's
Now I've noticed that that's new. This global health that you mentioned, this is now part of the curriculum. It's like, oh yeah, we're going to do a month in Africa. I mean, that's like you mentioned Johns Hopkins was there a long time ago. I'm sure they've probably expanded by now, and other universities have their tentacles in other parts of the world. So I would agree. My mission experience has all been short term. Now, we're running out of time a little bit, and there was one thing I wanted to touch on. There are people who are critical of medical mission work. It's like, well, you guys go there for a week and you do this and you do that, and then you're gone. And if it's surgeries, there might be complications, and also you're kind of you're competing with the local docs, if there are any. And in fact, in our missions, we're very careful not to go where there are local physicians because we're giving free care. So we go to I mean, the really rural areas where they've never seen a physician; they don't even know how to find one. So we eliminate that competition factor. But then it's also kind of a cheat for the government, which is not providing the care it's supposed to provide in most cases. And it's like, well, this mission group's coming; we'll let them take care of it. So, speak to that for 2 minutes. What do you
sure.
have to say?
First of all, I would say I'm probably the most critical of anybody I know of short term medical missions, because when you live long term in a country, you're kind of bridging the gap. You're part of the medical community of that country. You become part of that, especially living 4 years in Bolivia with my family. We were part of the community and we became part of the Bolivian medical community. So I kind of see things from both sides. From my perspective, the best organizations to work with are ones that have a partnership with an existing organization in that country, and that partnership with that existing organization has some leadership and autonomy, as well as some authority in the direction that that organization is going to take. So the organizations I'm involved in now, one is called Solidarity Bridge, and I accompany teams of mostly surgeons, and they have a partner organization in Bolivia called Puente de Solidaridad. And Puente, that organization in Bolivia, guides and directs all operations as far as what's going to happen in the country. And the volunteers that come down from the US, the primary job is to train the surgeons and the healthcare workers who are there in whatever activity, specialty that they have, in order to increase their capacity to be able to care for their own patients. And so those types of organizations, from my perspective, are the best ones. And the other thing is to always understand that it is an exchange. It's an exchange of talents. So when you go, you bring your skills, you bring your education, you bring your service and your heart, and you come away fulfilled. You come away with this camaraderie and this solidarity with people from all over the world that will change your worldview and will impact personal relationships that you have. So I think as long as you do it the right way, it's a wonderful experience.
Well, I'm glad I asked that question. Okay. So, Dr. Sherman, we're going to wrap up. What else would you like to add before we close?
The only thing I would like to add is that I believe that this last idea that you talked about, is extremely important to understand what organization that you're going to be affiliated with. And I'd be happy so people can contact me. I'll help them, guide them to the right organizations. And the second thing is just to realize what you said before about, some type of remedy to burnout. If you're feeling overwhelmed with all of the bureaucracy of medicine here, I think that taking a trip overseas to volunteer is a great way to at least address that situation.
Okay. How can people contact you? And I'll put this information in the show notes as well.
Sure. Yeah. I have a website, joeshermanmd.com, which is very simple to remember. And they can contact me, excuse me, by my email, joe@joeshermanmd.com. That's the best way.
Fantastic. Well, Dr. Joe Sherman, I want to thank you very much for appearing on The Art of Medicine.
Thanks for having me. I appreciate it.
Well, before we close, I'd like to give another thanks to our sponsor, locumstory.com, a resource where providers can get real, unbiased answers about locum tenens. I'm Dr. Andrew Wilner. See you next time. This program is hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on The Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests, and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com